Welcome to Cancer Newsline, a podcast series from the University of Texas MD Anderson Cancer Center. Cancer Newsline helps you stay current with the news on cancer research, diagnosis, treatment, and prevention, providing the latest information on reducing your family's cancer risk. I'm your host, Lisa Garvin. Today, our guests are both from our Department of Radiation Oncology, Dr. Benjamin Smith, who is an assistant professor, and Dr. Deborah Cuban, who is a professor in radiation oncology. Welcome to you both. Basically, what we're talking about today is an article that was in the International Journal of Radiation Oncology, of which Dr. Smith was a co-author, and you were looking at urology practices that also had a radiation component. So tell me the basis of your study.
Right. So in the last decade, there's been a increasingly common practice pattern of large urology practices acquiring their own radiation equipment and then offering patients radiation treatment within the umbrella or the framework of the urology practice. This has been a very contentious issue with heated debates between urologists and radiation oncologists as to the wisdom of this practice arrangement. But to date, there's been very little actual science or study of these practices and how they may impact care, or even just how frequently or commonly they're available in the community setting.
Why are these cropping up?
Well, that's a good question. So in around 2000, 2001, a new type of radiation called IMRT, or intensity modulated radiation therapy, was developed, which is a really wonderful technology which improves our ability to spare normal organs but still treat the organ that contains the cancer. And so IMRT has become increasingly used for prostate cancer. IMRT itself, especially in its early years, was associated with a very favorable reimbursement rate, and so that created quite a bit of interest in that technology, both within radiation oncology and then in other specialties whose patients often receive radiation.
So you were looking in Texas alone, is that correct?
That's correct.
What did you find with respect to these integrated practices?
Yeah, so we found that these integrated practices are relatively common in the state of Texas. There are 12 such integrated practices in the state, and 28% of urologists in the state of Texas are members of one of these practices. About 1 in 3 urologists is a member of such a practice. The practices tend to be located in large urban centers, and they tend to be located in places that already had other radiation therapy treatment facilities.
Because you found that in a lot of cases, the urology practice and the radiation oncology practice were not even in the same location.
Yeah, so that was a different issue. We were also interested in the structure of these practices. So what I mean by that is, were these practices set up so that it was just one big practice in one building with a bunch of urologists and then the radiation center within that same building, or were the centers more geographically dispersed? And so on average, what we found is that the centers where urologists were seeing patients tended to be dispersed over a relatively large catchment area, consistent with the idea of sending the urologist close to the patient so that patients wouldn't have to travel far to actually see their urologist and receive urologic care. But in contrast to that, the actual radiation therapy treatment facility owned by the urologic practice tended to be in just one location and in a location different from where urologic care was provided. So that if you were a patient and you went to see your urologist and you had a prostate biopsy that diagnosed cancer, if the urologist referred you then to go drive from that clinic to the radiation therapy facility owned by the practice, on average a patient would have to drive about 26 minutes to get to that radiation facility. In contrast, if the urologist sitting in the room with the patient were to refer the patient to the nearest radiation oncology facility, the patient would have to drive about 9 minutes.
And Dr. Cuban, you would probably argue that MD Anderson has been doing this sort of multidisciplinary team approach all along.
Yes, exactly. But I think we feel probably that we do it a bit differently. So we are all here in one place, and we are really committed to giving the patient the best care from all specialties and putting those specialists and specialty treatments together. So typically in our multidisciplinary prostate cancer clinic, which we hold multiple times a week, just about every day of the week, when patients would come in, they would automatically see a radiation oncologist and a urologist. And if it's a more advanced cancer, then we would also bring in medical oncologists in the case that there were some drugs that were applicable to that patient. So here, it's always been a team approach, and that's the basis for all of our treatment at MD Anderson. It's especially important for prostate cancer because in prostate cancer particularly, multiple treatment options are available. And many times, just one treatment hasn't been proven to be far better than the others. The outcomes might be similar. They might have different complication profiles. So we are really committed to giving patients all of their options and to try to lead them through those to find the one that may be best for them. So, yes, that's always been our premise, but it's sort of here, all in the family, all among us. We're all MD Anderson faculty, and we really try to take the best interests of the patients as the first consideration.
And it sounds like there's kind of a business driver going on here, and maybe patients would be pushed to a radiation facility even though that may not be their choice or that may not be the most optimal treatment. I know I'm treading in controversial waters here, but it sounds like it's a funneling operation.
Well, that's definitely the concern. And so there's ongoing research to try to sort out, is that what happens in real life or not? And some of that research hasn't been published yet. So I think we kind of eagerly await that further research, but it certainly is a concern of whether or not these practice structures are organized to have the patient's best interest at heart.
And so, many times we often wonder if the patient is getting the wrong impression, that perhaps they're made to think that, their cancer is so aggressive and so quickly progressive that they need to immediately go seek out the treatment that's being recommended instead of thinking about it, doing a little bit of research about it, perhaps getting another opinion and making sure that they get all of their options. So it is so important that the patient knows what all of their choices are and not that they should rush to do just one thing that may or may not ultimately be in their very best interest.
And I think prostate cancer in particular is unique because men do have a choice, depending on, their PSA level and other diagnostic factors. So
Absolutely.
They really do have more power to say, I want this and this and not this.
Absolutely. And now a choice additionally is not just which treatment, but no treatment. So I'm sure you've heard, all of the information very recently on active surveillance. We've always done this. In the past, it was called watchful waiting. Now it's actually a little bit more aggressive watching type approach called active surveillance, where the patient is watched very carefully. But this is a topic of great discussion now because we know that there is a lot of overtreatment of prostate cancer, and that there are patients who are perhaps elderly, perhaps ill, or perhaps have very slowly growing cancers who may never need treatment in their lifetime. And quite honestly, it just kills us to see patients come in and hear that they've been treated, hear that they've been told that they need to rush very quickly to treatment when, in fact, it's our opinion that they may not need treatment ever at all.
Yeah, I saw a patient for a second opinion who is an 82-year-old man with a PSA of about 4 and Gleason score 6 prostate cancer in 1 out of 12 cores. So the lowest of low-risk prostate cancer, and he was receiving radiation therapy in the context of one of these 12 practices that we had identified in our study. And you really wonder if that patient really needs radiation, if there's any potential benefit for him, or if there's only harm.
So it sounds like, obviously here we're at a comprehensive cancer center. A lot of people come to us for treatment, but out there in the world, it sounds like prostate cancer might be one of those lucrative cancers that people can really, rake in the bucks and the patients.
That is so. And that's exactly what we worry about. So prostate cancer is, a very common cancer with several treatments, and as you say, many of which have very good reimbursement. So, we just have to, I think, be very careful that the right things are being done to patients for the right reasons.
And Dr. Smith, what do you hope your study and your article will do? What do you hope to start?
Yeah, so as far as I know, this is the first article in the academic literature to try to study this phenomenon and understand it. So I hope that our research will add to a growing body of knowledge about these practice patterns. And, we want to keep an open mind. So there may be strengths to the practice patterns. There may be limitations. But this is kind of a first step of trying to develop a body of research to understand the strengths and limitations of these practice patterns and their impact on patients.
In a nutshell, what would you tell? Obviously, a driver for a lot of patients, especially with radiation oncology, because of all the treatments, is convenience. So they may be swayed by something that's in their backyard as opposed to driving to the medical center or one of our regional care centers. How do you overcome that?
Radiation is the gift that keeps on giving, and the side effects of radiation can be with you for your entire life. Also, the benefits of radiation can be with you for your entire life. So I think that convenience really needs to take a back seat to quality, because you want to get the very best treatment, because if there's something wrong with your treatment, you'll have to live with that for the rest of your life. So, 8 weeks is a small price to pay for the next 20 years of your life.
And Dr. Cuban, what would you say? You have the multidisciplinary prostate clinic where you have like a treatment, like a decision tree where patients can use that. What would be your advice to a man who may be pushed by his urologist into a certain treatment? What would you tell them to do?
I would certainly tell that patient that if that's the way he was feeling about the consultation and the opinion that he was getting, to certainly seek out another opinion. And obviously, we're biased, but, I think that a clinic such as ours, where the patient will not just get one opinion, but an opinion from radiation oncology, urology, which is the surgical opinion, of course, and also medical oncology and active surveillance, that's the best of all worlds. And that way the patient can hear from the specialists why one treatment or another may be better or worse for him particularly, because there are so many factors that go into that decision. Typically, prostate cancer is not one of those very fast-growing, fastly progressing cancers, so that you can step back, think, regroup, get another opinion. Even if it takes a couple weeks to do that, that cancer is not going to be very much further along in that amount of time. And it is certainly worthwhile to have the right treatment the first time. It's so critical. So I would tell that patient, just step back a minute, tell the doctor he's going to take time to think about it, and really get some good advice.
And Dr. Smith, what's your hope for these integrated practices? Are you looking for standardization? Are you looking for guidelines, regulations?
I conducted this as a descriptive analysis. There's a heated policy debate right now as to whether or not such practice arrangements should be considered legal or not. They're conducted under there's the Stark Law, and there's an exemption to that for in-office ancillary services such as and radiation therapy is included in that, and blood draw or laboratory services or pathology services can fall under that framework as well. I think the hope in studying this phenomenon and developing literature about it is to help inform the policy decision of whether or not these arrangements really are in the best interest of our patients and of our society's medical system. And so, I think the hard literature on that is still to be published and generated, but the goal of such literature is to inform the policy.
And do these integrated practices, obviously prostate affects a lot of people. What about the other urologic cancers like bladder and penile and testicular? Are these also being seen in these practices?
Not as much, actually. So prostate cancer is far more common than the other malignancies that you mentioned, the bladder, the penis, and the testicle. They're also more difficult to treat. Very often they're very complicated cases, and so they're not as sought after, I guess we could say, as something that can be treated easily and quickly and with very high reimbursement. So they typically to this point have not been problematic, and we tend to see those type cases at major medical centers and major cancer centers. So that hasn't been a problem with this type of practice to date.
So it sounds like words to the wise: do your homework, take a step back, and get a second opinion. And it sounds like you've injected a very interesting thing into the debate. So it'll be interesting to see how it turns out. Great. Thank you both. If you have questions about anything you've heard today on Cancer Newsline, contact Ask MD Anderson at 1-877-MDA-6789 or online at www.mdanderson.org/ask. Thank you for listening to this episode of Cancer Newsline. Tune in for the next podcast in our series.